Cerebral edema. Cerebral edema. ANS. The most basic definition of cerebral edema is swelling of the brain. It is a relatively common phenomenon with numerous etiologies. Cerebral edema categorizes into either vasogenic, cellular, osmotic, and interstitial causes. It arises from a variety of causes, including head trauma, vascular ischemia, intracranial lesions, or obstructive hydrocephalus resulting in interstitial edema. In cerebral edema, the relative volume of brain tissue increases as the brain tissue swells with edema. This increased relative brain volume decreases perfusion, blood to the brain, and the pressure can cause further damage to both the edematous and non-edematous brain. Clinical presentation of cerebral edema is variable, ranging from asymptomatic to severe autonomic dysregulation, coma, and death. Pathophysiology. Vasogenic cerebral edema, the most common form, results from the disruption of the blood-brain barrier. With the disrupted blood-brain barrier, ions and proteins flow more freely into the extravascular space, which causes osmotic draw of fluid into the brain interstitium. Common causes of vasogenic edema include mechanical trauma, high altitudes, inflammatory lesions, brain tumors, hypertension, and infarction. Cellular or cytotoxic edema, cerebral edema following metabolic insults, cytotoxic edema, such as hypoxemia or ischemia, results from failure of brain cells to actively extrude, causing progressive cellular swelling. Traumatic brain injury and stroke cause this form of edema. Interstitial cerebral edema results from the outflow of cerebrospinal fluid from the intraventricular space to the interstitial areas of the brain. Patients with hydrocephalus or meningitis are examples of those affected by this etiology. The increased pressure against the cerebrospinal fluid, CSF, and brain drives fluid into the brain parenchyma. The fluid accumulates in the extracellular space of mostly the white matter, causing the cerebral edema. Osmotic edema generally stems from derangements affecting osmolarity, such as hyponatremia, diabetic ketoacidosis, DKA, or similar metabolic pathologies. The cells of the brain pull water from the plasma in these instances, resulting in widespread edema. Etiology. Neurologic causes. Tumor. Trauma. Hypoxia. Infection. Metabolic derangements. Acute hypertension. Non-neurologic causes. Hepatitis. Rye syndrome. Carbon monoxide poisoning. Lead poisoning. High-altitude cerebral edema. Clinical features. Patients may have a history of trauma, a hypoxic event, cancer, metabolic diseases, or other factors which can help identify the possible etiology of the cerebral edema. Localized cerebral edema can cause dysfunction of the edematous brain and include weakness, visual disturbances, seizures, sensory changes, diplopia, and other neurologic disturbances. For diffuse cerebral edema, the patient may have headaches, nausea, vomiting, lethargy, altered mental status, confusion, coma, seizure, or other manifestations. With diffuse or focal cerebral edema, the patient can develop increased ICP, which typically presents with headaches, nausea, vomiting, lethargy, cranial neuropathy, altered mental status to coma and death. Evaluation. CT scan of the brain. This can show the edema, which is visible as areas of low density and loss of gray/white matter differentiation, on an unenhanced image. There can also be the obliteration of the cisterns and sulcal spaces. MRI can show increased T2 and flare signal changes, hyperintensity, within the brain. ICP measurement and monitoring. Management. Treatment of intracranial hypertension and cerebral edema is ideally directed at the underlying cause. Treatment of cerebral edema is twofold: prevent further injury from the cerebral edema and remediate the original insult causing the cerebral edema if able. Remediation of the original and ongoing insult can include correcting metabolic derangements, controlling hypertension, removing intracranial lesions, shunting hydrocephalus, depending on the etiology of the cerebral edema. The edema should be controlled to prevent further injury and complications. Glucocorticoids have shown potential benefit in cerebral edema secondary to vasogenic edema. Avoidance of hypotonic fluids is a strong recommendation in instances of cerebral edema, as they can worsen cerebral edema and cause elevations in ICP. If the cerebral edema is causing elevated ICP, various methods are available to help control ICP, including positioning, hyperosmolar therapy, antipyretics, sedatives, paralytics, modulation of PCO2, and surgical intervention. In the management of malignant middle cerebral artery stroke presenting with severe cerebral edema, osmotic agents can be used to create an osmotic gradient across blood, thereby drawing fluid intravascularly and decreasing cerebral edema. Mannitol is the primary agent used at doses of 0.25 to 1 g/kg body weight and is thought to exert its greatest benefit by decreasing blood viscosity and to a lesser extent by decreasing blood volume. 3% hypertonic saline is also commonly used to decrease cerebral edema and can be administered as a 5 ml per kilogram bolus or a continuous infusion, monitoring serum sodium levels closely. It is considered relatively safe while serum sodium is than 160 milliequivalent/dl or serum osmolality is less than 340 mosm. A decompressive craniectomy is a neurosurgical procedure wherein a part of the skull is removed and dura lifted, allowing the brain to cell without causing compression. It is considered as a last resort when all other ICP-lowering measures have failed. Other supportive treatments include extraventricular drainage of the CSF, avoiding straining and coughing, inducing paralysis in patients who are intubated, keeping the neck straight and elevated to allow for the brain to drain with ease, inducing coma with barbiturates, minimizing the use of PEEP, inducing hypothermia to suppress cerebral metabolism. This is often done for several days, but extended hypothermia makes the patient susceptible to systemic infections and hypotension. Thank you.